Thank you for inviting me to come here and try to tell you why we have been doing studies on Rituximab and in ME/CFS. So this is how we are working. We have in Bergen, which is in the western part of Norway, we try to combine the work on clinical trials, harvest biobank samples to use in the laboratory, trying to increase our understanding of the disease mechanisms. So why did we, as oncologists, I treat lymphoma patients and brain tumors in my daily work. Why did we get interested in ME/CFS? That was in 2004. We had first patients with a long-standing moderate ME/CFS. She got Hodgkin lymphoma, and she received chemotherapy for lymphoma and reported to us that this did a major effect on her ME/CFS symptoms, as she told us. We just registered that and wondered what that could be. In 2008, we had the same patients with a severe ME/CFS patients, been bedridden for 8 years. She got non-Hodgkin lymphoma and reported in the same way a major effect on her ME symptoms after chemotherapy, which was combined with Rituximab. She got Cyclophosphamide in the therapeutic regimen together with Rituximab. And then Ola Mella and me, he's my colleague, we decided that we wanted to investigate this further. Cyclophosphamide is a cytotoxic drug with broad immunosuppressive effects on several lymphocyte subsets, while Rituximab is a very specific monoclonal antibody that targets the B lymphocyte specifically. So we decided to try to investigate this further in separate clinical trials. And while we started with this, from the last 10, 15, 14 years, we had at least 8, maybe 10 patients with ME/CFS who have independently reported to us they have got their cancer disease and reported benefit from cancer therapy on the ME/CFS symptoms. Most of these have received chemotherapy with cyclophosphamide and some also with Rituximab. Just for those of you who are not familiar with the immune system, we have many subsets of the white blood cells, and we have the innate immune system, which is the unspecific and rapid first-line defense with the granulocytes and the monocytes and the macrophages. And we have the adaptive or the more specific immune system with the lymphoid cells, which have memory, which is specific and takes some time to establish. And in this adaptive lymphoid system, we have the B cells that I will talk about. They mature to plasma cells. Their main task is to make antibodies to many foreign molecules as part of our defense system. And we have the T cells that Maureen talked about. They attack foreign molecules and infections, for instance virus, inside cells, and may also attack cancer cells, which is the new, if you have heard of the new immunotherapy for cancer that's been revolutionizing some of our cancer diseases, it's based on this principle. While in autoimmune diseases, the immune responses are directed against the body's own proteins. Autoantibodies from B cells, for instance, against self-proteins. And we have heard about that before today, both in the lecture and from David Anderson. Just also introduce you to the concept of B lymphocyte depletion. Rituximab is a therapeutic, engineered monoclonal antibody that is made so that it is directed against the molecule, which is called CD20, which is located on the surface of B cells. And it's used for treatment of B cell lymphomas and some autoimmune diseases. It attacks the B cells and gives a rapid and major reversible reduction of B lymphocytes, both malignant in case of lymphoma and normal B cells that has this molecule on the surface, but not the plasma cells. The mature plasma cells, which are the main producers of antibodies, they do not have the CD20 molecule on the surface, so they do not get depleted. And neither do the stem cells in the bone marrow, so the cells will replenish. luckily. So I haven't the time to go into, I will use the time for the Rituximab study, but one or two slides for the previous experience that we have got. First, we did a case series. We decided to start with the Rituximab, but we have made studies for both Rituximab and Cyclophosphamide. But Rituximab is less cytotoxic drug, so we started with that. We did first a case series with only 3 patients. Then we did a small randomized and placebo-controlled phase 2 trial published in 2011. Only 30 patients. 15 had got 2 infusions of Rituximab and 15 had got 2 infusions of placebo, followed for 1 year. And then we did an open-label phase 2 trial with maintenance treatment to get some experience, to be able to learn something, to be able to make a protocol for a randomized study. The conclusion from these initial experiences was to us that we thought that there was a subgroup of ME patients that could benefit from B-cell depletion therapy. So Olav and I, we interpreted the observed clinical improvements as probably related to Rituximab intervention. That was partly also because we saw no patient that responded before they were at least 4 months, 3 to 4 months from first infusion. That could be an argument against a major placebo effect. But it is in oncology and also in studies having evaluated Rituximab in autoimmune diseases have shown us the importance of doing larger and randomized and placebo-controlled trials before conclusions. That could be especially important in diseases like ME/CFS, that partly have to rely on subjective and self-reported outcome measures. So just one slide from the open-label study that maybe that we registered. And this is a study. Is a plot for SF36 plots for physical function, vitality, bodily pain. There were 28 patients in this study. 14 we called for major responders. 4, the green ones, were moderate responders, and 10 had no clinical response during follow-up. And it's a time axis on this one from baseline to 3 years. And what you can see, when these curves go upwards, it means that the patients are improving. And for instance, for physical function, you can see that at baseline, these patients are very low, both in vitality, bodily pain, social function, extremely low values, and also for physical function. And at 3 months, there is no difference, but then they start to improve as we could see it. And these are filled out by the patients themselves. You see that half of the patients that were recorded as major responders had substantial increases in these values, sustained over time, while the blue ones, the non-responders, had no effect. So this was also supported by measured level of physical activity. This group, the red ones, they had more than 9,500 steps per 24 hours. So there was no doubt to us that there is a subgroup of these patients that improved, because all the questionnaires and the measured steps was shown in that direction. But what was the cause of the improvement? This was an open-label study, and we could not make any conclusions from that. But I think this shows us that the patients improved. So what were the limitations from this first study? The first study was the first one to evaluate Rituximab. It was a small study. There could be a major selection of patients, which maybe is one of the problems. The primary endpoint for that study was negative, while the secondary endpoint showed that after 6 months, the curve seemed to favor the Rituximab group. The second study had a major limitation that it was without the placebo group. That makes it very difficult to draw any firm conclusions. And you have the problem of the heterogeneity of the patient sample that the previous talker talked a little bit about. So these results has to be verified or refuted, and that was the purpose of the Rituximab trial, which was multicenter, national, randomized, double-blind, placebo-controlled phase 3 study with 151 patients. Half of them got rituximab, first 2 or placebo, which was saline with some added albumin to make it look exactly the same. 2 infusions 2 weeks apart, and then the maintenance part with the lower dose, but given at 3, 6, 9, and 12 months, with follow-up for 24 months. And we had Canadian consensus criteria. The age was between 18 and 65 years, and the disease duration could be up to 15 years. But if the patients had mild severity, they should have been sick for at least 5 years, so that we didn't include patients that could have a transient disease in the beginning. Very severe patients that could not be transported to the hospital were not included. And we had endpoints based on fatigue score that I don't have the time to show you in detail, but we also measured SenseWear armbands to measure level of physical activity, the SF-36 questionnaires, and we did sub-studies on endothelial function that we will report in separate paper, cardiopulmonary exercise tests, and also for gastrointestinal function. So the study the patients were very loyal to the study. Only 2 patients out of 151 dropped out, and very little missing data, between 0.5 and 1.3%, mainly less than 1% for the different variables. And there were also a high degree of exposure to the drug, either rituximab or placebo. 139 of the participants received all the planned 6 infusions. 7 received 5 infusions, and 5 received 4 infusions, in addition to the 2 patients that dropped out. So the mean age was, as you can see, 36 years, so on, 37 and 35 years in the rituximab and placebo group. Approximately 80% were women, and you can see that almost 30% of the patients, 31% in the rituximab group and 28% in the placebo group, had either severe or moderate to severe disease, being partly bedbound or at least housebound. You can also see that 27% in the rituximab group and 16% in the placebo group had been ill for more than between 10 and 15 years. So many of the patients had been ill for quite a long time, and the mean duration of disease was approximately 8 years, you can see here. 75% had an infection prior to ME/CFS, and the baseline characteristics also shows us that, for instance, SF-36 was about 32 and 35 in the 2 groups at baseline, indicating that these patients have a high degree of symptom burden at baseline. I think this variable, almost all the different studies include this SF-36 physical function, which has a scale from 0 to 100. So that can be important to look at when you look at inclusion criteria. In some studies it can be 50 or 60 even, but it should be. This indicates that the patient that we have included have a high symptom burden. So just a few slides on, because this study can also provide information of other diseases in ME/CFS patients and what they use for medication and so on. So there's some other, in addition to the response data. For instance, 40% have self-reported that they have allergy. 9% and 10% had depression or anxiety, and fibromyalgia, comorbid fibromyalgia was reported by approximately 7% to 8%. And to note, 40% of the patients had a first-degree relative with a known autoimmune disease, which is probably higher than what you would expect. From previous treatments that these patients had tried, you can see that 60% had tried any form of cognitive therapy at least once. And 40% in rituximab and 51% in placebo had tried some kind of graded exercise therapy. You can also see the numbers here for those having tried vitamin B12 injections, 40%, long-term antibiotics, approximately 20%, and the same for low-dose naltrexone, 20 and 35%. This is in the paper. The paper was published in April, so it's available online. But then when we look at the fatigue score, throughout follow-up, you can see that the blue line is the placebo group and the red line is the rituximab group. There is no difference between the groups at any of the time points. Neither if we divide it in subgroups by severity, by disease duration, by gender, or with or without infection up front. And the response rate was 30%, fulfilling the predefined response criteria, which was at least moderate improvement for 8 weeks, so consecutive weeks. It was no difference between the groups, 26% and 35%. The number were even higher in the placebo group than in the rituximab group, 26 and 20, with no difference. Look at the SF36 physical function. You can see that these patients improve a little bit during 2 years follow-up. They increase from a median 32 and 35 at baseline to a median 45 to 46 at 18 months. So they are increasing by 12, 13 points on the SF36 scale, but again, with no difference between the groups, neither in the subgroups that have stated down on the slide. If you look at physical function in the rituximab, I told you that there were no differences between the groups, but if you look at the different levels of improvement for the patients, you have patients here in both rituximab and placebo groups that improved for more than 30 consecutive weeks. This one, and they increased from 32 to more than 60, almost 70 in the SF36 scores. But you can see also in this group there are equal number between the placebo and the rituximab groups. So at all levels of improvement or worsening, it seemed to be the same, at least no significant difference between the groups. And I was glad to see that those 15 patients having noted worsening of the disease during the trial, this one, that's falling lower on the SF36 scale by follow-up. There were more of these in the placebo group, 9 in the placebo group and 6 in the rituximab group. So we can say that neither improvement or worsening in this trial was associated with the type of intervention. Also for the steps, I showed you that the questionnaires showed that the mean values for patients for SF36 was improving in both rituximab and placebo groups, and that's also supported by the steps. It increases not so much, from about 3,200 to about 4,000, the mean steps per 24 hours, equal between the groups. The adverse events, we had no unexpected serious adverse events. We had, you know that in a clinical study, everything that happens to patients that gets them admitted to hospital will be a serious adverse event. So if you break a leg that will be a serious adverse event. But you can see that there were serious adverse events in 20 patients in the rituximab group, 26% versus 19% in the placebo group. And the difference were mainly infusions-related reactions that we sometimes had to keep the patients in the hospital for additional hours because we had to turn down the velocity for the infusion because some patients had infusion reactions. Not to be worried about, but that we wanted to use longer time for the infusion. We had some unexpected that we registered as so-called SUSARs, suspected unexpected adverse events. That was one metrorrhagy, a bleeding, followed by a hysterectomy in the rituximab group. One patient was admitted because of chest pain, but it was not confirmed coronary artery disease. That was in the rituximab group. And one patient had a transient paresis in the left side of the extremities, which was in the placebo group. There were equal number of infections and antibiotic courses in the two groups. So, to conclude from this trial, I think that it's well conducted, but I think it's clearly negative, with no significant differences between rituximab and placebo group. It gives information on the natural cause of symptoms during 2 years follow-up for patients participating in a clinical trial. And then we can see that during these 2 years, there is a gradual increase, slight increase in for instance, the SF-36 score or the measured levels of steps per 24 hours. So most of the responders in this trial reported a rather slight to moderate improvement of varying duration. There were few patients that had more than 10,000 steps and reported a very major improvement based on the self-reported questionnaires. But we also saw some of these in the placebo group, and that makes it impossible to detect any significant differences. So the majority, 60%, reported a stable clinical course during follow-up. I think that ME/CFS has no firmly established pathomechanisms and no standard defined objective outcome measures, and it emphasizes the need for randomized and placebo-controlled trials. And it's also difficult to know what should be the proper outcome measures in a clinical trial. How should we assess improvement in a reliable way? We are now trying to do a pilot with continuous registration of physical activity, and have applied to do a study with these small new devices that you can put on patients to get continuously measuring of, for instance, steps, how long time you are lying down, so on, to try to see if that can give us some more reliable endpoints for a new trial. So issues that may affect the outcome is the heterogeneity of patients. And if there is a subgroup with autoantibodies, maybe we don't target the autoantibody by rituximab because it is the mature plasma cells that are producing the antibody that are not affected by rituximab treatment, like in lupus, for instance, could be one explanation. Patient selection. I cannot say to a single patient. I have a lot of emails from patients from inside Norway and other parts of telling me that they have had repeated effects from rituximab intervention and the same time course for the different treatments outside trials. I cannot say to a single patient that you haven't had effect from this treatment, but I can say that at the group level, there are no indications of an effect. That means that even though there may be patients that could have responded to B-cell depletion, they are too few to give any impact in a clinical trial when we select the patient based on Canadian criteria. So it's not useful to do a trial with rituximab based on Canadian criteria. So if we are going to do that again later, we need to select patients based on some kind of laboratory marker, I think. Or be able to show that it is antibody mediated in some way. I think this is the last one. We have also performed an open label study with cyclophosphamide in ME/CFS. 40 patients with moderate to severe ME/CFS, did not include mild patients and not the very severe. They got 6 infusions with 4 weeks interval. This was based on these observations that I told you about, and also a pilot study with 3 patients that we have performed, which is not published. Now, we had follow-up for 18 months, but when we saw the data from the rituximab study, we decided to prolong the follow-up to get better data for response durations. So now we follow these patients for almost for 44 months, more than 3 years, so that we can have better data when we are going to decide what to do next. Because this is a cytotoxic drug, it has a broad immunosuppressive effect gives a moderate depletion of lymphocytes at the doses that we are talking about. It's not a major depletion, and there has been no infection problems, for instance, or hematological toxicity, but it is a cytotoxic drug. So the trial has a focus on feasibility and toxicity. There are interesting data on responses that we will submit for publication during the year, but we have to learn from this recent experiences in the Rituximab trial. How should we interpret the response data? This is an open label study with no placebo group, so we cannot draw any firm conclusions. So we are now working on our biobank samples from this study, serial samples from all patients in the clinical trial, trying to look for association between clinical characteristics and laboratory data, underpinning either strengthening or weakening the case for a new randomized trial. Because is this a true drug effect that we are observing? Is it placebo mechanisms, or is it natural variation? I don't know. And if we are going to pursue the Rituximab track further later, that will only be if we can select a group that have a high chance of response. Patients should not be treated with Rituximab based on Canadian consensus criteria. That I can say for sure. So the Kavli Trust has been our cooperation and support since 2011. And we also had support from the Norwegian Research Council, a private donation from Me and You Foundation, Norwegian ME Association, and the regional health trusts. And the Haukeland Hospital has applied for a patent for the B-cell depletion principle in ME-CFS, which probably will not be of any relevance, but they had applied for this when this study was performed. So that was it.